Guys, this has been an extremely robust discussion, very, very informative. What I want to do in the few minutes that we have before we have to end our discussion is to kind of go around and get some final thoughts. Since Corey's the senior ranking, I'm not going to start there. I'm going to start at this end. So he'll be the last one to do it. So Paul, just for the audience, just some kind of parting wisdom for them about the management of lung cancer at the current era.
So I think for me, it is, I think, quite impressive how quickly things have changed. Certainly, since I began looking at lung cancer as a fellow, but even as a attending within the past few years, just how radically quickly the field has shifted with the first immunotherapy nivolumab approved for squamous cell back in 2015, and now this just wave of monotherapy and combination therapy trials now in the early stage space, which has given us a lot of gains and things to chase after. So, you know, as much as we have done some measured criticizing of things, that's against that backdrop of just the enormous amount of progress that we've made in this very short period of time. So I remain sort of over the moon optimistic about where we're going to go, particularly as we work hand in hand with our surgeons and radiation oncologists. I think it's, you know, another era sort of now where we're working much more closely with our colleagues to really push things forward. So yeah, another reason why I'm pretty optimistic.
Heather?
So I share Paul's enthusiasm, and I'm just going to put a plug in to make sure that we're remembering to do the testing up front for our patients and not get too swept up in the immunotherapy enthusiasm that we don't do the right care for our patients who do have the driver mutations. And as that list keeps growing about the key driver mutations that we can act differently for our patients if we know about them, I'm just going to mention that, and that don't jump as soon as you get that PD-L1 level. Get that mutation testing result back, and then you can carefully craft the best treatment for each of our patients. But yeah, just so much happening. It's really exciting.
Yeah, and some, you know, Paul made me remember that when I think Corey and I started in lung cancer, we used to argue as to whether or not lung cancer was even treatable.
We had debates of that sort.
Yes, and I can show you editorials. I can show you editorials written in the early '90s. Some of them by current lung cancer thought leaders about
emeritus.
About how lung cancer, it was the con that lung cancer is a treatable disease, and we had this rash of trials against best supportive care, and so that's what I remember. And to your point, the progress has just seemed exponential in our understanding. Tiziana?
I'll echo what the panelists have said so far. I would add really understanding better how to manage immune-related adverse events. I think we're extrapolating the data on how to manage that from what we've seen in other diseases, but really how do we really manage immune-mediated pneumonitis? What is the best way to approach immune-related myocarditis? These are severe toxicities that are, you know, becoming increasingly common because we're treating more patients. So certainly I think there needs to be more efforts in that, in educating patients and making sure that we really focus on how to optimize that management.
Kristen?
I would say multidisciplinary care is best, and we can do more when we work together.
Yeah.
And I echo what everybody else has said. By the way, that was formally debated at ECOG exactly 25 years ago by Einhorn versus Bonomi. You can guess which side each was on. Should we treat advanced lung cancer? Now we're talking first, second, third, even fourth and fifth line treatments. I think it's critically important we export the benefits we've seen in advanced disease to the curative setting, and I'm personally enthused about both the neoadjuvant and the conventional adjuvant trials. Majority of these patients still get surgery up front. Anvil's accruing like gangbusters, comparing Nivo to observation, to the point that we have to actively plan the successor trial because it's ahead of schedule. And that's probably the component of the Alchemist trial that's ultimately going to save Alchemist. We need to compare concurrent and consolidative versus consolidative and locally advanced. And maybe you can work on this, Heather. We need expedited mutation testing. $30 in 30 minutes is what I've heard. Some sort of liquid assay, and they're getting better and better. Granted, their sensitivity isn't as good as their specificity. But the faster we know the answer, the better off we'll be, the better off the patients are. It is so frustrating dealing with these constant phone calls. When is my mutation testing going to be back? Should I start the checkpoint inhibitor? Should I wait? incredible. It wasn't an issue in the past, but it's a major issue now.
Well, thank you all for your contributions. This has been fantastic. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.